Please.
Test.
Now it's moving. Is it working? Yeah.
Okay, welcome back to part 2. We had a technical difficulty with the sound cutting out, so we restarted, and we'll have 2 videos this week. So the last thing I was going to say about mobile diagnostic medical screening services, on a project we're working on in South Carolina, there is a nursing school that does a lot of outreach into the community, and they have a mobile van that goes and provides services. And one of the things that they're doing, which I think is really interesting, is they're going out to areas that have high migrant populations and providing family planning services for women. So your regular checkups, pap smears, and such, and providing contraception to women who may not be permanent residents of South Carolina, but they're getting them access. So there's some really interesting and innovative things that are being done with mobile to bring, again, services to communities in the spirit of what Outpatient is, which is to serve those underserved populations. Okay, so home health care, which Mr. Youngblood mentioned. So when people leave his setting, they will go home, but they may still need some skilled nursing or home health aid services. And we see this after surgery, maybe wound care, physical therapy. So after my mother got a hip replacement, she had home health, and the physical therapist came to the house. Occupational therapy, speech pathology is done, and then medical and social services. In addition, they provide often durable medical equipment, which we have a list of different kinds of durable medical equipment that individuals will only need for a short amount of time, so they don't want to buy necessarily their own hospital bed or wheelchair or certain supplies, so they are able to get those through home health care. So here's a little bit of data on the demographics of people who use home health care, and then the payment sources. So who utilizes home health care more? Well, who's at the top? Let's talk about gender first. Females, yeah. So women make up over 60% of the individuals who utilize home health care. And then Adrian said the elderly. So they 65 and older crew, right, is everything but 15%. So it's utilized by the older adults. And again, it's provided as that continuum of care after you leave an inpatient setting. You're not quite ready to be on your own, but the services you need don't really require that you stay in that setting anymore. So you can get those in the convenience of your own home. So who pays for most of this? It's the largest payer source. Medicare. That makes sense, right? Because we just said it was our older adults who are utilizing it. Followed by Medicaid, and then all other providers as well. So, I mean, this is a big, in 2014, total payments were over $80 billion. This is a lot of money, right? Okay, another really important outpatient service is hospice. And so hospice has a completely different focus of care compared to what the rest of medical care is, right? What is the goal of hospice? Is it to cure?
No,
Just to keep you.
it's to ease the pain of death.
Yeah. So it's provided for terminally ill persons, right? And that is defined as a life expectancy of 6 months or less. There are people who have a life expectancy of 6 months or less that live longer than that. And that is, this is on average. Most, they may have gotten a diagnosis that they have 6 months, they may live longer, but it's typically for people who are at the end stages of a terminal illness. And the emphasis, as Bethany mentioned, was to ease that pain. So pain and symptom management. So we often call palliative care. So we're no longer trying to intervene to cure someone, but we want them to be as comfortable as they can be. And what is really another important piece of hospice care, and maybe more important not only for the individual who is in care, but also for the family and social network of the person, is that psychosocial and spiritual support. And it's really this holistic model of care that we see with hospice care. It's very different than all the other kind of care we have, and so important. So there are many different considerations. Again, meeting the patient's physical needs, but it's not about, curing, it's more the management of the pain. Meeting, again, not just the patient's, but the family's spiritual and emotional needs. The family members who are going through this need support before and after the patient's death. And it's this focus on quality of life at that end so that they can transition as peacefully as possible, not prolonging life at this time. Any questions about hospice care? No. It feels sad to us, but it's not necessarily sad, right? We think from our medical model, our illness model is cure, but this is a really important part of life, is that we all end up not living, right? Okay.
I think it adds a lot of dignity. Provides dignity to people when going through that part of life. So.
And I think it helps, especially if you're not. Hospice providers are trained so specifically to care for the needs, answer the questions, provide support for family members who this might be the first time they're dealing with something like this. And it provides peace and dignity to all. So the majority of types of hospice agencies are freestanding, followed by hospital-based. Nursing homes, interestingly, don't really, you might think that they would be a big player, but they're not as large of a player. It's just not their business.
In home health, in
Nursing home.
in hospice, the category.
For hospice, for.
Yeah, usually they will have a contract with the hospice organization, and they'll bring them in, and then they'll.
Yeah.
And it really is a great opportunity for the family, because literally they gain almost twice as many nurses to care for that family member.
So even when they stay within the nursing home, the hospice providers come into the nursing home. Or are home-based. So when we think about the coverage, Medicare hospice benefit is the biggest provider. Why is that?
Age.
Yeah, most of us still, that's the hope, right? We live a long life. And so the people who are utilizing hospice care are those who are getting it through their benefits, through Medicare, so they're 65 and older. But for those that don't receive it through Medicare, there are the other sources. So those that don't meet the qualifications for Medicare receive it other ways. Very small, do self-pay or charity care. Most individuals meet it through their government Medicare insurance. Okay. When ambulatory long-term care services, there's really the two big ones of this is case management. So the case management is just that coordination among a variety of health services and referral. And really the objective of case management is to find the most appropriate setting to meet the patient's need. And then the other major one is adult day care. So this complements informal family care for individuals with professional services. So families who have, it's often used by individuals or families of individuals with a dementia, type of dementia, Alzheimer's often, that just allow for both the family to have maybe a time off, but also that the person to get some care outside of the home. Okay, public health services. So health departments, by nature, are in communities, right? And though they are in the business of population and community prevention, they do provide quite a few services that are important to communities. So in general, the push is for public health departments to get out of the business of clinical provision. But and some of the research we've done here at ETSU and elsewhere that I've done, we're finding that when it makes sense, when there's other providers in communities, health departments can divest of this work. Because really, a better place to get these services are in a primary care setting, where you have that coordinated care, versus the health department, where it's not that same continuum of care. They do provide it, but it's best to have it, if possible, in a primary care setting. In communities where there is less access, you see that they can't get out of the business. Things that will probably never, ever leave the health department are STI or STD, sexually transmitted disease clinics, and screening and treatment for tuberculosis. Those are two things that are, though they are not prevention, right? People have your screening for STIs and STDs and tuberculosis and providing treatment. Those are things that are really important for the overall health of the community. Well baby care, and along with well baby care, you have WIC, Women, Infant, and Children Services. They go pretty hand in hand. Family planning services. We were just looking at some of the data we collected in South Carolina, and health departments provide family planning services for the uninsured. So women who, and men, but primarily it's women who want to plan their families, either they're planning to get pregnant, are pregnant, or want to not get pregnant, which is really what a lot of the services are. They go to the health department and they can get those needs met. School-based clinics and services, these are often done in partnership or with the health department. So they come in and do eye screenings, hearing screenings. We used to have them come in, and I'm not sure if they still do it, for scoliosis screenings. Did you guys get that in school? You leaned over and they checked your spine. I have scoliosis and I found it in my school-based clinic.
That was the most uncomfortable thing though.
You have to take off your shirt.
In front of everyone, I was 20 people just bent over to feel weird.
Your spine, it's curved. And they also provide ambulatory or mental health, system mental health services. Another piece of this that's considered ambulatory or services or outpatient is prison-based care. Kind of falls into other. Okay, so community health clinics are really fascinating, and I enjoyed this iteration of the book. Went into a lot more detail about some of the really great data we have on how good they do. So to be a community health clinic or CHC, it's a private nonprofit organization funded predominantly through the federal government. But to be considered and recognized as a community health clinic, you have to be located in a medically underserved area, or MUA. Okay, and so that is a community that does not have very many primary care providers or delivery settings. So they're underserved medically, as well as poor health indicators in the populace. So really there is a need in that community to provide these primary care services, because there's not enough providers and the community is having poorer health. They really focus on family-oriented primary and preventative care and dental. They serve a lot of people. So in 2015, they served 24.3 million patients. So those are individual patients, but those patients had more than 96 million visits. And so they provide this care to the most vulnerable population. So 92% of their patients are below 200% of the federal poverty level. So these are very, very poor individuals. And about a quarter are uninsured. So we would think that the deck was stacked against community health centers, that they would try their best but still have not that great health outcomes. But they have some really amazing quality and performance standards, and they meet high metrics across the board. So these community health centers have been able to find models that work and provide high quality care to those communities. Okay, so community health clinics do get funding from the government, and then the other sources are Medicaid and then private sliding fee for patients. So what a free clinic is a general ambulatory care center for the poor, homeless, and uninsured. They do not get support directly from the government agency or a health department. There's no fees are a very, very nominal charge. So how do they get funded? Who funds their work? Donations, yeah. They do a lot of fundraising. They may also get foundation fund, like grants and things like that as well, but they're not directly supported by the government. And the other way that they can provide these services for free or at a nominal charge is that they are services are delivered mainly by trained volunteer staff. So it's not like me going in there and checking your blood pressure. It's doctors and nurses.
Is this like the RAM clinics?
RAM clinics are a good example. RAM clinics are like a day or a couple days, like a weekend long, but that provide free services. Free clinics are open. You know, they most of them have limited hours. They have very, very small staff sizes, again, because it's volunteer. But they do provide care for those that really have nowhere else to go. And there's about 1,200 nationwide. So and they have a network as well. They're not a large provider, but again, they're an important provider of primary care. And so the last thing we're going to talk about is telephone triaging. So these are systems staffed by nurses who receive patient calls. I think Mr. Youngblood talked about the commercial in the Super Bowl or something where the family called the doctor, the nurse in the middle of the night, or the doctor.
One of my 1,000 tangents.
Yeah, tangent. I remember it. But it's really that. It's for triage. So they can access. This is typically through your health insurance. You'll see it on the back of your insurance card, the nurse number or what have you. They can access your medical history. They can also help you. They can view, like, if you've gotten some sort of lab results, radiology, they can help you get connected with where you need to go next. But they have standard protocols, and they consult when necessary with primary care physicians. They can direct. So this is a service. I think one of the hopes is that this can be utilized in such a way to reduce utilization of EDs and even urgent care centers. If your symptoms are such that you have a virus, it's probably just as good to stay home and drink fluids and take your over-the-counter medicine. But they do have standard protocols, and they can walk you through things. Okay, so again, just going through these kind of definitions, and we talked about these. So flip back to the front, back to slide 8 or 9. So we went through these definitions again. Don't require an overnight stay. And so going back to primary care, the focus again is on prevention, diagnostics, certain therapeutic services. You get health education, counseling, minor surgeries. What's a minor surgery that you might get?
Wisdom teeth removal?
Wisdom teeth removal?
Is that minor?
Depends on your experience, if they're impacted or not.
Yeah, I'm gonna be away from mine.
It wasn't that. Just
What?
put your headphones in.
So
I didn't have
Tell me
there's little things, like I think of kids, infants, tongue tie, they'll fix a tongue tie. They may do other little things that I don't know if that's even considered a surgery, but minor surgeries. mole removals, things like that can be done. Okay, secondary care. So primary care again is that focus on prevention and diagnostics. Secondary is short-term in nature. Typically, consultations with specialists can include hospitalization, more routine surgeries, and like that rehabilitation piece. So you already have something, you've already broken something, or you've had a surgery and you need rehab after. Tertiary, as we all know, is more complex level of care. These are conditions that are more uncommon. Tertiary care is institutional based primarily, highly specialized, rendered in large teaching hospitals, and may be long-term care. So what are some examples of tertiary care? Care for trauma, that's one. So like trauma centers, trauma from accidents primarily, be it car accident, gun, falling, open heart surgery, anything. What are some tertiary cares? What are some really complex things people get done? Huh? Brain surgery?
Like,
Brain surgery?
like transplants?
Yeah, transplants are definitely very highly complex, specialized, require long-term care. Burn treatments are a big one. And another one with our littlest patients would be the NICU. Our youngest and littlest patients. Okay, so as I mentioned, we have like this, so if it's primary, secondary, tertiary, if you're doing it from like primary is at the top, secondary is in the middle, and tertiary is at the bottom, what does the frequency pyramid look like? Upside down, right? Kind of like a cone or a funnel. So more frequency, 75 to 85% of the population require only primary care. Okay. Then the next more often is secondary, and then about 5 to 10% of the population needs tertiary care. Now, if we were to keep them in that same order, but look at cost, what would that triangle look like? A pyramid, right? So it's more the care that those 5 to 10% of the population get. It's very costly. Okay, so there's a couple different definitions. We won't belabor these too much, but these are WHO and then the institutional, the IOM. So WHO says it should be based in essential healthcare based in scientific methods, affordable in cost, and maintained at every developmental stage. And is typically your first level, or should be your first level of contact with healthcare services. So when we talk about maintained at every level of development, that's from cradle to grave. You should have it, and it should be universally accessible and acceptable. And accessible is a word that there's actually many levels of accessibility, and often we say the 4 A's of access, and acceptability is one of them. So availability, affordability, accessibility, and acceptability, the 4 A's. So We can always talk more about those, but we'll leave that for another day. Okay. Also, it brings healthcare close as possible to where people live and work. And so there's 3 elements: point of entry, coordination of care, and essential care. So that point of entry, what do we think of when we think of point of entry?
Primary care.
Primary care, what's the thing we don't like?
Gatekeepers.
Gatekeepers, yeah. But that's really what, it's the point of entry. So healthcare systems, where they're organized around primary care, it's the first contact that the patient makes with the delivery system. And then that role of that gatekeeper, again, is just doing that, the gate. Patients have to see them before they can get a referral. Coordination of care, it should coordinate healthcare between the patient and many delivery components. It's meant to ensure comprehensiveness and continuity or continuousness. One thing that we know globally is that countries geared towards primary care have better health levels and satisfaction and lower expenses. So again, if we can do the things we need to do at the primary setting, and we can mitigate the need for secondary and tertiary, people are happier because they're not sick, and they cost less, and they have better overall health outcomes. And so we see that primary care helps to mitigate adverse health effects of income inequality. So again, this primary care being available in the community at an affordable price, accessible and acceptable, can mitigate that. And we regard primary care as essential care. And the goal overall for primary care is to optimize population health, minimize disparities to ensure equal access. So you can see this coordination of care wheel, and it just goes over all those different things, where really the goal is to have primary care in the middle, and they help to coordinate and make sure there's comprehensive care for all. IOM, very similar main pieces of their definition. So the things, accessibility is so that ease that a patient can interact with a clinician for any health problem, right? So accessibility doesn't say has health insurance, but that they're able to interface with that clinician. And then there's accountability on both the clinical system and the patient. So we are responsible for the parts of our health that we can influence. And we should be judicious in our use of resources as individuals. So there is a lot that we can impact in our health. There are other things like getting cancer. There are life things, but also there are people who do certain life behaviors that don't get cancer. So there are things we can influence, and when in those areas we need to be responsible. And the clinical system is accountable to quality care, using resources efficiency, and behaving ethically. Okay, so when we think of the role of primary care in the Affordable Care Act, so one thing it's done is increased Medicare and Medicaid payments to primary care providers. So to help with that difference in reimbursement that you get for specialists versus primary care, there have been increases in payments to Medicare and Medicaid patients. There's also some new incentives for funding for scholarships, and then as many of you guys illustrated in your rural health homework, the loan repayment for providers in underserved areas. I enjoyed reading your papers. Did you guys learn something doing that rural health paper? Alaska. Wow. Anyway, so I enjoyed reading them, but that's one of the things. What?
Alaska's only good for visiting.
For visiting? There are people who love frontier, living in the frontier, not just Alaska and the frontier states. They love the
Pacific
distance.
Northwest.
I'm talking Montana,
Oh,
Canada.
Pacific Northwest. There's a lot of people there.
Oh.
I'm talking about great, expanses of land and very few people. But it's also expanded healthcare center programs and the capacity and creation of additional training programs. So it has part of the ACA is to try to change. They've put in in place some attempts to help balance. We're not getting anywhere close, but try to tip the scales where it's not so heavy specialists versus primary care. So there are multiple reasons for growth. And so we can see this is kind of teeny, but you can see from 1980, about 16% of services were provided in outpatient setting. And in 2013, it was 67%. So that's a huge jump. So there's a couple of different reasons. Changes in reimbursement. So there have been constraining on the costs for inpatient services. So hospitals don't make as much on inpatient services as they did previously. It's not as lucrative. But the reimbursement models favor outpatient services. So they can now do things, things can be done in an outpatient setting. It's cheaper for hospitals to provide services in outpatient. They don't have to have that actual physical bed with all the staffing and all the things that go along with keeping someone in a hospital. There have been fewer payment restrictions for dialysis, chemotherapy, and surgery. They're often paid as fee-for-service. So again, as more things are coming under the auspice of pay for performance, these are things where you can still do the fee-for-service, which the more you do them, the more money you get. So that is also part of that that reimbursement payment structure. Physician practice factors. If they can do specialized care, they can perform more services with less time. Again, that equals more money. And if you have a specialized center, say a surgery center, or a very specific type of surgery or type of care, the more it's done by those providers, the better quality. So if that's something they do a lot, that's good for the patient too. So there's those. We talked about new technology. That's really the big one. And then managed care restrictions have led to the growth. But one of the things that I think is really important for us to talk about is our own societal factors. How many of us like to go spend the night in the hospital? The bed moves up, right?
You can eat. Oh yeah. TV. Cable.
Cable for those of you who don't have cable,
No,
but no Netflix.
Yeah.
So people prefer. Most people want to be home, right? You want to be in your own bed with your own PJs, eating your own food and not hospital food, though it's better than it used to be. But we have a preference to obtain services at or near our home when possible. So that also drives that that market. Let me think of it from the market, a free market perspective or a market perspective. Give the people what they want, and then they'll use those services over the hospital-based ones. Okay. Patient-centered medical homes, they're not a new thing, but they're an important team-based approach. So where you have one place with an interdisciplinary team of physicians and allied health professionals. The orientation is that the whole person, integrated care, and enhanced access to care. So again, a one-stop shop for your services. This was a newer addition to this book, was this discussion of community-oriented primary care. Just to let you know, this is not a US-based. Currently, this is not really a big push in the US, but it's a really, I think, something we should strive towards. So it emphasizes the relationship between the population and the community and personal health care. So it's got the elements of good primary care delivery, so the things that work really well, being close to the fit in the WHO's accessible, universally affordable, mitigates disparities and increases equity, but also adds in population-based approach to identify and address community health needs. So you've got that individual primary care within this overarching population health improvement piece. So the guidelines that they set forth, the WHO set forth, is universal coverage reform, organizing services around the people's needs, health in all sectors. So what does health in all sectors mean? Have you heard of things called health in all policies before?
We all need to be healthy.
No, we all do. But to integrate and think about the impact of health on different policies and within different sectors. So when we talk about health in all policies, that is something we do talk about in the US. So say you're trying to decide where to put a school. And the school, some person in the community dies and they donate their land to the community. So you're like, awesome, we have this land, we're gonna put a school there. Where is that? Do people donate really awesome land? No, right? They donate land that they want to get some tax write-off, right? But then you have to think about the impact on health, the impact of getting water, getting electricity to some place that may be not easy to get at. Is it close to the community? So thinking about this holistic health and that. We see a lot of health in community design, and Tennessee's doing a lot of really cool stuff around dual and more than dual use. Roadways are different things that go through TDH. So they're really thinking about how they can build things that can be utilized by people in different ways. Not only transportation, other sectors, but just really thinking about health as part of every piece of society. So that's pretty ambitious. Okay. And that plays into that collaborative policy design. And one thing we do, especially us smart, intelligent people who think we have a lot of great ideas, is we may come up with really great ideas and not engage community stakeholders. So there's an increase in really engaging with the end users, engaging with the people in the community to find out what are their needs so we can organize services around them. What are some of the impacts of some of the things we think are really great, but there might be other impacts on them and their community. So really community-oriented primary care is like taking primary care and like putting public health and population health on top of it. There are international examples of this, but again, this is something to strive towards. We're not there yet in the US. Man, you guys are gonna get out early, just like Adrian wanted.
Thank you, Adrian.
Thanks for me. Okay. I just don't have as many good stories as Mr. Youngblood.
I would say they're good.
He's got stories. So, one other really important provider, we're not done yet. You got a couple slides left. Come on. Stick with me. Is CAM, or Complementary and Alternative Medicine. So, so these can cover like a lot of things, fall under complementary and alternative medicine, but it's other resources that are not those that are intrinsic to biomedicine. So here's some examples. Homeopathy, herbal, acupuncture, use of natural products, meditation, biofeedback, spiritual guidance, and prayer are some. So what we know about reasons for seeking CAM is that most people who use complementary or alternative medicine have already explored conventional, what we often call Western treatments, but have not had the results that they want. So they may not have had the help for chronic diseases or things like persistent pain. They also seek it if they're trying to avoid or delay complex surgery or things that they may consider toxic allopathic treatments. Often they also just want this kind of more holistic opportunity to talk through their health with someone and listen and be understood, trying to figure out how they can do get care in a way that is different from traditional. There is not a strong evidence base for CAM. I think there's just not a lot of randomized controlled trials on complementary and alternative medicine. It's so broad. Some types of CAM are more effective than others, but it's often there's less of an evidence base for it. And it might seem less familiar to you because it's used more and it's more popular in Europe and Canada than the US. So do any of you guys use complementary or alternative medicines?
So how does that work for prayer for health? I mean, like, do you just
Does a doctor come in here and say, I'm praying for you, and then slaps you with a fee of like, my prayer cost you?
No, that would be if you're in the biomedical. This would be spiritual guidance, so it may be with a guru or
My
yoga.
cousin is a universalist priest and she works for a hospital.
Yeah, so as a chaplain or
Yeah, I think that's her title as a chaplain.
yeah, so chaplains do exist within the hospital system. That's a little bit different, but yeah, this would be someone who is not from the biomedical perspective.
Oh, this is like being anointed with oil at church. Oil. Excuse me, oil.
Oil?
Oil, yes. Oil.
Oil at church. Yeah,
You
that
can
could be
anointed
it.
with oil at church, like they'll like put it on your forehead.
That could be so
They'll pray.
getting spiritual, like it within a faith-based, yes.
Sorry, Adrian.
Oh, no,
Adrian's
I was just
like-
gonna say, with the lack of research for like all these natural
Uh-huh.
products and natural treatments, how can they justify having accredited, like essentially homeopathic naturopathy colleges in the country? Because I know
acupuncture, but
I worked with in the biology department. One of the secretary in there, her daughter goes to school in Portland at that naturopathy
So they
school.
in
of naturopathic
general, naturopathy, they could have evidence for some of theirs. There just might not be for my grandma's herbal formula. Like that has not been tested, but she still gives it to me, you know, and it helps.
Has about 5-6 months of whiskey in there.
Whiskey, yeah. But there is, and then they can be certified by their national organizations. It does it. I'm not as familiar with naturopathy.
Right.
like essential
I
oil.
guess
Essential oils are really popular now. That is like
You mean
boom.
oils?
What about like
Oils.
the diffuser? That's essential oil.
Yeah,
Perfect.
Did you have?
I know.
So we see this also in more traditional, I mean, like in rural areas or areas that may, again, like your grandma has something, or someone in your community is a herbalist, or you have a friend who deals in herbal stuff. Remember, a lot of our medications came from plants, so like there is a lot of. I mean, it's not like it's just like. Just because there's not evidence-based does not mean it doesn't work, but I'm just putting it out there that the evidence base is not as strong.
Yeah.
Right. Well, I was saying I have a friend and coworker that wanted to open up a shop for a while, so I was just sort of looking into it myself, just to see what all went into it.
My mom could team up with you and throw holy water in there too.
I mean, there's a lot
believes
of
in that. I kid you not.
when we talk about health, it's not just physical health. There's a lot of spiritual and emotional health, and a lot of this meditation, spiritual guidance. This can help with a lot of anxiety induced high blood pressure, high heart rates, things like that. So there are things that relaxation can help with. Acupuncture is a very popular way to treat pain. It's used by women who are trying to get pregnant as well. So there's, this is a big part of this field of outpatient and primary care. Again, it's usually individuals who either have had exposure to it, either through their family or through their culture. They're avoiding, trying and delaying, going through some sort of surgery, or they've gone through the regular westernized medicine and it hasn't worked, so they're ready to try something else. You said you've used Cam?
Yeah, I mean, it's just funny having to hear that we have such, in Africa, in Nigeria. I mean, it's one of the strong contenders for the
Care that people get?
Yeah, I mean, it's either, because there's this thing about hospitals and practices that you are not, according to the code, you are not allowed to advertise these hospitals.
Yeah, you can
But
advertise.
these other guys can
do
advertise,
whatever.
traditional guys can advertise, so
Mhm.
they're always in the news, in the papers and
Yeah.
everything,
Yeah.
and they
And-
have a lot of recognition.
Because you're not supposed to profit from healthcare per se. It's a moral thing. So you're not even you can't advertise even health insurance. That's not you can't.
Yeah, so it's not the capitalistic market
No,
for
no, no,
healthcare.
no. You can't advertise your hospital, your rehabilitation or nothing.
But these other guys just go to
Yeah,
town.
they can do whatever. they
But
want.
the
Then again, people want
medicine
them.
person,
Because it's in the name of God or something.
No,
it's not
not
about some of them.
necessarily.
It's not about God.
It's
Some
not
of them-
God.
it's not God.
It's
Yeah,
not
yeah,
religion.
no,
It's
it's
just
not-
the
it's-
practice.
The practice, then
Oh.
yeah, we have the
Yeah.
we have the ones that are really over time. Maybe they've had some seemingly results. Or you have some that are just
That's
you
the
just-
main.
So,
Let's be truthful here. Yeah, they've
What
gotten
do they
results
do?
because those were the first people on ground before the Western medicine came.
Yeah.
So it's not like some results. So some of them do just the traditional healing.
Mhm.
Then some of them do the religious healing, and there are some people that do the two.
Yeah.
You know.
What do
but
they do
it's-
for the
And some
healing?
of them
I wanna
believe
hear
that
this. Give me a
staphylococcus-
procedure.
For example, if somebody has a fracture,
Okay.
so the ones that combine the two will take a chicken, then break the leg, then reset the chicken, then do the same thing they do to the chicken, they will do to you. Then whenever the chicken starts working, you can start working.
It's chicken
I
guys.
am not kidding. Am I lying? I'm not kidding. Yeah, not a fake
How did
chicken, a
the
real
chicken
chicken.
start walking?
A real chicken. So whatever ritual they do on the chicken, they're gonna do on you.
But they could be setting the rate very efficiently, right?
They can, but then if it's a compound fracture that has all sorts of complications, you are in trouble.
Yeah.
Because we all know that
They
not all.
purposely hurt the chicken
Yep.
Yo,
to only poultry.
It's
like,
a
only-
chicken, guys.
it's a chicken.
But like y'all only look at chickens. Like,
What?
like why a chicken?
I have no idea.
Oh my God.
where the-
I mean, and
Because you
ours-
can't break a cow's leg.
No, you can't.
It's
They're trying to compare the healing rate of the
No, the way a
chicken.
foul lives.
So we
the
heal
fracture
the
cannot
chicken
live
away.
for
But
so
it's
long.
absolutely not
I mean,
because
after a while,
fracture
foul.
heals in like 6 weeks,
Yeah.
then the chicken heals
Like 2
faster.
Yeah, kind of faster.
Like 3 to 4 weeks. So I don't know. There's,
I mean,
but they have to do all
Yeah,
sorts
like
of
we
rituals.
have that, not chicken wise, but if you get sick all the time, they believe like in like the evil eye, so like
Yeah.
you have to like
We also
slaughter,
believe that
slaughter a
somebody.
goat for good luck and
Yeah.
it'll cleanse you. I just drank holy water 2 weeks ago. My mom
Yeah.
genuinely thinks that like we're cursed from the evil eye.
So there's a lot. So when you do randomized control trials, right? You have blinded where some people get placebos,
Yeah.
right? And we do that because there is some effect of just taking the pill. It
Yep.
doesn't matter if it's a sugar pill. So we can feel better after we've gone through a lot of different treatments that are just that placebo effect or that. And so I mean, and that's Western traditional Chinese medicine. There's a lot of placebo effects and a lot of the things. If you feel sick and you start to ruminate on it and then you start, oh man, now this starts to hurt a little
Yeah.
bit more
Yeah.
and that hurts.
Yeah.
Versus, hey, I've done something that's gonna heal it. Oh, well, it hurt more yesterday than today, so there's a lot. It's complicated. It's complicated, right? Okay.
Oh yeah, you can buy one of your chickens.
Smart.
So I've had students do their whole projects on CAM because they got really interested in it as well. So there is research out there. There's a lot of information about it, and it seems like you guys. I learned some things just now. Okay, so we had the pleasure of actually seeing primary care in other countries previously. So this is just some of the highlights that I pulled from your book that talked about other types of primary care. I miss Transled. And most of this we've already read about in this or learned about this semester. But really, like, in all of these examples, primary care is at that centerpiece, and then typically they're the gatekeeper, and then they coordinate those referrals. And so, any questions about outpatient services and primary care? So remember, all primary care is outpatient, but not all outpatient is primary care. There's a lot of things that we get outpatient that is not fit under that term of primary care, okay? All right, enjoy your break. Make sure you get your cases and your homework number 5 done and keep working on your papers. And we will see you guys in 2 weeks. No class next week.
No,